Good morning. Welcome to theheart.org. My name is Professor Tony Gershlick from the University of Leicester, UK. I'm here at Munich at ESC 2012, and we're discussing some of the late-breaking hot topic sessions with various of the numbers of the PIs. I'm delighted to be joined by Elena Arbelo from Barcelona, who's presenting in the hotline session some data on AFib ablation. And so Elena, tell us a little bit about the background to the study, a little bit about why you decided this was an important trial to do.
Okay. In 2008, the European Society of Cardiology started a program called the EURObersvational research program, which aimed at describing or getting robust data on real life and real practice of cardiology across Europe. Within that program, there was the feature of the Sentinel registries, which wanted to see new tools and new technologies for the treatment of cardiovascular diseases. As ablation has become one of the options that a patient with this particular arrhythmia, atrial fibrillation, we decided to have a look on how this was being practiced within the European Society of Cardiology.
So very important real-life data.
Yes.
How many patients in general who have atrial fibrillation go on to ablation?
Well, this is a very small minority. The atrial fibrillation can affect up to 2% of the overall population. And although I do not have the exact numbers, it is estimated that less than 1 in 1,000 probably is actually getting to undergo this procedure, invasive procedure. And especially the type of patients that undergo this intervention is very different to the overall population of the atrial fibrillation community.
So atrial fibrillation, as the population gets older, will be increasing, and maybe
yes,
this number is an underestimate. Tell us a little bit about your study and what were the methods and how you analysed the data.
This was intended as a pilot, the pilot phase of a larger registry, and it particularly focused on centers with high volume of expertise in this area, in ablation of atrial fibrillation. So at least they had to perform 50 ablation procedures per year of atrial fibrillation.
All atrial fibrillation?
Yes.
Okay.
The median number of ablations of atrial fibrillation was 140. This was 72 so centers. These were high expertise.
How many centers?
This was 72 centers across 10 different European countries. I think I remember it was 4 northern countries, Western countries, 3 Eastern. I cannot remember exactly. So it was a little bit of yes, and also all the areas of Europe: northern, southern, eastern, western. So it's a nice sample of the practice across the continent.
So how many patients over how long?
So initially for 1,410 patients were included, although 19 patients did not undergo the procedure for several reasons. So the in-hospital phase included 1,391 patients, of whom we obtained all the cardiovascular risk profiles, socio-demographic information, all the cardiovascular tests that were done before, during the admission and at discharge, all the technical aspects of the procedure, the complications and the results, both in the acute phase and also a 12-month follow-up, 1-year follow-up, which we will be presenting. We are presenting in the ESC conference.
So the audience will be interested to know what sort of patients were you included, what their age range was, whether they were uncontrolled atrial fibrillation, on how many medications, that sort of thing.
This is very interesting. So as I was saying, the population that underwent the ablation procedure was young. The median age was 60 years old, and only a third were above 65 years old. Only a third of patients were females, And in general, they were healthy individuals. 40% had absolutely no cardiovascular risk factor or structural heart disease. 50% of patients, although, had hypertension, and the other cardiovascular risk factors were only a minority, 8% diabetes, and that's it.
Were they very resistant atrial fibrillation patients?
Yeah,
Had they had attempts at DC conversion and not?
Yes, these were all patients that had undergone at least one intraarrhythmic drug trial that failed, and most of patients underwent the ablation due to symptoms. They still had symptomatic AF. I also have to say that most AF it was paroxysmal. That means that the arrhythmia came recurrently, even though they were treated with antiarrhythmic drugs.
So these were not patients with persistent AF?
This was 2/3 of patients were paroxysmal, and then
really?
The two
That's
others.
Interesting.
Only 7% had what we consider now with the new guidelines long-lasting, persistent, or permanent AF.
Okay, so let's get to the results. So 1,400.
1,391 underwent the procedure.
Okay, and follow-up was for how successful was it?
Let's start with the in-hospital phase. Obviously, in AFib ablation, we do not consider acute success because in the initial phase, it's very you have the end point of the procedure, but you do not know whether that is going to sustain long term.
Sure.
So, but what we can say is that within the in-hospital phase is that the complication rate was low but not negligible. It was 7.7%, although major, considered to have, like for instance, the cardiac tamponade that needed drainage, that was the main.
Okay, so
major, that was only
7% complication
yes.
rate, but low incidence of major.
Major, 1.6%.
Okay.
That was it.
So, and the success rates?
Then, at 12 months,
yep.
The definition of success was no recurrence of any atrial arrhythmia,
yep.
apart from common atrial flutter, after a 3-month blanking period. With or without antiarrhythmic drugs. As this is a registry, we did not tell the investigator to stop drugs at 3 months or anything.
No.
So the success, yes. So the success was 74% of no documented arrhythmia at 12 months.
And were you able to tell which patients were going to be successful through looking at their demographics?
Yes, we analyzed the main baseline data, also the atrial fibrillation characteristics and echocardiographic, and basically in the multivariate analysis what came out was, as has already been described, is the type of AF. The younger the AF, paroxysmal AF, had a better outcome than non-paroxysmal AF, and also the left atrial diameter. One surprising finding was that if we analyze the recurrences within the first 3 months, which is considered to be a blanking period, the atrium is still developing the scar and the fibrosis, and therefore we do not know whether the results are going to stay or not. But even so, within having a recurrence within the first 3 months was a very strong predictor of recurrence during the follow-up.
As you might expect.
Yes. Although this doesn't matter, this doesn't mean that you need to re-ablate as soon as 3 months, because as many as 60% of patients with a recurrence in the blanking period did not have a recurrence in the follow-up.
So we're coming to the end, and I'm really interested to know, were there any patient types that you would now not recommend not to have ablation?
Okay, one has to be very careful with the information that we're getting here on the success of the ablation, because we, as a registry, we did not intend to influence the general practice of cardiology across the centers. So the follow-up was very diverse across centers. Some centers only performed periodical ECG, so they could have missed asymptomatic episodes of atrial fibrillation, and then others went all the way to the other side and implanted a Holter monitor. So the important thing is that provides this. The most important thing that provides this registry is how in real life the centers are actually complying to what is being recommended in the guidelines and the experts' consensus.
They are compliant.
In some areas, yes, in some areas not. For instance, it was surprising for us to see that anticoagulation after the procedure was patients with a low cardioembolic risk, a CHA2DS2-VASc score of 0, were still 50% under anticoagulation 12 months after the procedure. Wow. Whether on the other hand, 25% of patients with more than one CHA2DS2 score, they were not taking any anticoagulants. So there are some areas that are actually very surprising.
So we have to finish this, but we look forward to the full paper.
Yes.
It's clear that this is real life data that you've collected, but it sounds to me as though the most important observation is to try and ensure that when you're undertaking these procedures, you should, as much as possible, stick to the guidelines.
Yeah.
And that may be a very important observation.
Yeah, that's true.
Thank you very much for coming along, and
Thank you.
Look forward to seeing the full paper.
Perfect.
Thank you very much indeed.